Доброе утро, дорогие коллеги. Разрешите всех поприветствовать. И мы сегодня открываем нашу ревматологическую часть конгресса. Наша часть сегодня будет состоять из двух блоков. Первый блок будет посвящен проблемам аутовоспаления, и этот блок у нас представлен международной конференцией. Сегодня мы будем говорить о разных аспектах аутовоспалительных заболеваний. Сегодня у нас суммарно будет 6 докладов. Первый будет мой доклад, посвященный проблемам аутовоспалительных заболеваний. Мой доклад будет сделан на русском языке. И после меня будет 5 очень известных специалистов в области воспаления. Это иностранные спикеры. И я несколько слов расскажу о каждом из них. Второй доклад будет сегодня читать профессор Елда Билгинер. Профессор Билгинер является одним из ведущих специалистов по изучению семейной средиземноморской лихорадки. Она работает в университете ХЧТП в Анкаре. Это самый крупный университет в Турции. И, собственно говоря, это один из лидерских центров по изучению семейной средиземноморской лихорадки. Мы сегодня об этом тоже поговорим, потому что семейная средиземноморская лихорадка – заболевание этническое, и в мире больше всего пациентов проживает непосредственно в Турции, ну или вообще люди турецкого происхождения. Следующий доклад будет из еще одного очень известного статусного центра. Это университет Газлини, Генуя, Италия. Этот центр является центром Center of Excellence, да, то есть это такой очень мощный обучающий центр, и итальянские коллеги сегодня являются лидерами в детской ревматологии. Непосредственно Италия является, фактически этот центр является председательствующим в Европейской ассоциации детских ревматологов и ведущий специалист в области аутовоспаления в мире, не только в этом центре, в мире, доктор Марко Гаторна будет рассказывать про новое направление в аутовоспалении, это синдром недифференцированных периодических лихорадок или СУРФ-синдром. Следующий доклад представит профессор Азгур Касапкапур. Это один из ведущих ревматологов Турции. Это профессор, который работает в Стамбуле, в университете Керапаса. И самая большая выборка в мире пациентов по синдрому ПИФАПа, собственно говоря, принадлежит как раз турецким коллегам. И профессор Касапкапур расскажет нам про это заболевание. Профессор также является главным редактором журнала Turkish Archives of Pediatrics, турецкие архивы педиатрии. Это тоже очень хороший статусный журнал. Соответственно, мы тоже работаем с этим журналом в плане международных публикаций. Следующий доклад будет представлен итальянским спикером, который в данный момент работает в Казахстане, в университете имени Назарбаева в городе Астана. Теперь опять... Соответственно, докладчик Дмитрий Подиги. Дмитрий Подиги занимает позицию декана педиатрического факультета в университете. Доклад будет посвящен болезни Бехчета. Это тоже такое достаточно редкое аутовоспалительное заболевание, которое весьма распространено в азиатских популяциях. Да, и, собственно говоря, Дмитрий Подиги сделал большое исследование на территории Казахстана. И следующий доклад, завершающий, который будет показывать разнообразие аутовоспалительных заболеваний, будет посвящен моногенной волчанке. Это новое направление в детской ревматологии, о котором мы сегодня тоже немножко начинаем говорить. И докладчиком будет профессор Сулейман Аль-Маев из Саудовской Аравии. Это университет и госпиталь короля Файсала. Профессор Аль-Маев является ведущим специалистом Саудовской Аравии и президентом Ассоциации детских ревматологов Саудовской Аравии. Конечно же, очень хочется поблагодарить наших иностранных коллег, что они поддержали нас своим участием, о том, что они все откликнулись на наш призыв, наше предложение участвовать, и все подготовили свои доклады и презентации. Ну и хочу сразу сказать о том, что у нас доклады пойдут в записи. Это, честно, сделано для того, чтобы не было каких-то технических проблем со связью и по возможности было выдержано качество докладов. Ну и вторая секция у нас сегодня будет во второй половине дня. Мы начинаем в 2 часа. Вторая секция, она будет, соответственно, в очном формате. Эта секция уже будет посвящена вопросам неонатальной ревматологии. Мы немножко вчера на совещаниях неонатологов уже затрагивали эту тему, но вчера мы больше выступали для неонатологов. Сегодня мы будем, конечно, говорить не только для неонатологов, для ревматологов, для педиатров, поэтому сегодня будет более подробное выступление, посвященное этой теме. Ну и, собственно говоря, наверное, можем переходить к нашей научной части программы. И я начну сегодняшнее выступление с доклада, посвященного обзору отовоспалительных заболеваний у детей, и скажу о том, что от воспаления до отовоспаления прошло всего 90 лет. Да. Теория воспаления – это теория, которая была, скажем так, описана, да, нашим соотечественником, очень известным физиологом Ильей Ильичем Мечниковым в 1908 году. И Илья Ильич показал о том, что воспаление, да, является важной защитно-приспособительной реакцией. И основная задача воспаления – это та история, когда необходимо локализовать какой-то возбудитель, какой-то инфекционный агент. Собственно говоря, это ответная реакция либо на повреждение, либо на попадание инфекции. Воспаление должно быть строго дозировано, должно отвечать целям и задачам, которые необходимы для конкретного процесса. И всегда воспаление, как только купируется, да, локализованная инфекция, воспалительная реакция всегда идет на спад. Что такое аутовоспаление? Это самоподдерживающее воспаление, это история с так называемым воспалением, которое никаким образом не связано с конкретным инфекционным возбудителем. Да. Возбудитель, даже если есть, он не вызывает инфекционный процесс, он фактически является триггерным, и аутовоспаление – это самоподдерживающее воспаление, которое, ну, по сути дела, является таким контрпродуктивным, разрушительным. И история началась действительно в 1998 году, фактически через год после того, как было описано, найден молекулярный механизм для первый молекулярный механизм для воспалительных заболеваний, это была семейная симорская лихорадка в 1997 году. Две группы исследователей, Соединенные Штаты Америки, как раз группа под руководством Дэна Кастнера, и вторая группа, это французских исследователей, практически одновременно описали мутации в гене МЕФ, да, который называется Mediterranean Fever. Собственно говоря, это была история с первым исследованием в области генетики аутовоспалительных заболеваний. И в 1998 году уже Дэн Кастнер сформировал теорию аутовоспаления, которая, в общем, на сегодня практически существует все это время. Итак, аутовоспалительные заболевания – это заболевания преимущественно моногенные. Ну, на самом деле мы их делим на две группы. Это моногенные болезни и мультифакториальные заболевания. Да. Моногенные болезни, для которых известен молекулярный механизм, это группа из нескольких заболеваний. Суммарно их уже около 20. Есть так называемые классические формы, это криоперин-ассоциированный периодический синдром, семейная симорская лихорадка, ТРАП-синдром, синдром гипериммуноглобулинемии D, соответственно. Ну и есть еще порядка 15-20 новых синдромов, которые были описаны. Есть целая группа мультифакториальных заболеваний, где молекулярный механизм либо отсутствует, либо он неизвестен на сегодня, да, и среди которых это и болезнь Крона, и как раз болезнь Бехчета, которая будет сегодняшнее выступление, и юношеский артрит с системным началом, болезнь Стива и целое много, и подагра, и даже сахарный диабет имеет компонент аутовоспаления. В целом аутовоспалительные заболевания принципиально отличаются от аутоиммунных тем, что аутовоспалительные заболевания – это болезни, связанные с неправильной работой системы врожденного иммунитета, это клетки, это неправильная работа именно нейтрофилов, фагоцитирующих клеток, да, моноцитов, тогда как при аутоиммунных заболеваниях, конечно же, основной эффекторной клеткой является Т-лимфоциты. И как раз при аутоиммунных заболеваниях есть целенаправленная агрессия, выработка аутоантител против своих собственных антигенов, против своих собственных тканей, тогда как для аутовоспалительных заболеваний такого компонента, как правило, нет. И основная история здесь связана с тем, что клетки вырабатывают большое количество провоспалительных цитокинов. И, собственно говоря, вот эта вот неспецифическая реакция, связанная с выработкой провоспалительных цитокинов, является ключевой для всей этой истории. Типы наследования. Ну, заболевания связаны с, для них известны молекулярные механизмы, соответственно, гены все локализованы в соматических хромосомах, да, поэтому мы выделяем два типа наследования, либо аутосомно-доминантный, либо аутосомно рецессивный тип наследования. В отношении доминантного типа наследования здесь четко два из классических моногенных заболеваний. Это ТРАПС-синдром, мутация в гене ТНФ, РСФ1 альфа, и синдром КАПС, соответственно, это патогенные варианты в гене НЛРП3. Что такое доминантное наследование? То есть измененный генетический вариант находится в гетерозиготном состоянии, то есть повреждена только одна аллель гена, соответственно, вероятность рождения больного ребенка, да, с заболеванием составляет 50%. Рецессивный тип наследования, соответственно, родители являются носителями, да, соответственно, должно быть две копии гена пострадавших, да, соответственно, у здоровых родителей, которые являются носителями, вероятность рождения 25%, еще 50% вероятность для того, что будут такие же гетерозиготные носители, и 50% вероятность того, что не будет заболеваний. Но опять же, это так с точки зрения математики, это хорошо работает в больших группах, но в семьях не всегда это срабатывает. Ну и из заболевания с рецессивным типом наследования мы говорим о том, что синдром дефицита мевалонат-киназы является классическим представителем, а вот семейная морская лихорадка – это заболевание, которое характеризуется двумя на самом деле типами наследования. Это и классический рецессивный тип наследования, и доминантный тип наследования. Поэтому действительно для этого заболевания надо понимать, что если есть клиническая картина и гетерозиготный вариант, то мы считаем таких пациентов больными. С точки зрения патогенеза этих заболеваний, как раз тот самый триггерный фактор, патоген, сигнал опасности взаимодействует с клеткой, активирует внутриклеточный комплекс ферментов под названием инфламмасома. Эта активность инфламмасомы приводит к выработке провоспалительных цитокина интерлейкин-1 бета. Вот. И, собственно говоря, интерлейкин-1 бета, попадая во внеклеточное пространство, запускает вот этот самый каскад воспалительной реакции. И в чем история самоподдерживающего воспаления? В том, что эта молекула взаимодействует с рецептором как на своей клетке, так и на соседних, и заново запускает петлю обратной связи, и происходит формирование воспалительной активности. То есть, получается, воспаление поддерживает само себя. Воспаление не связано с каким-то конкретным инфекционным агентом. Воспаление не направлено на локализацию инфекционного агента. Этиология и патогенез заболеваний связаны в том, что есть мутации, или, как правильно говорить теперь, патогенные варианты в генах, которые кодируют белки, ответственные за работу системы врожденного иммунитета. Все это приводит к активации инфламмасом. Действительно, патогенные варианты могут носить как характер активирующий, так и инактивирующий характер, но в конечном итоге все это приводит к спонтанному высвобождению большого количества интерлейкина-1 бета. Вот эта гиперактивация системы врожденного иммунитета приводит к хроническому, рецидивирующему или персистирующему системному воспалению. А вот воспалительные заболевания это гетерогенная группа, это редкие генетические заболевания, и поскольку воспаление, дети, это, конечно же, лихорадка, поэтому, конечно, эти пациенты похожи, да, или попадают под группу так называемых часто длительно болеющих детей, вот, но и если у пациента есть дополнительные симптомы, это существенно позволяет вычленить эту группу заболеваний по сравнению с пациентами, да, с классическими инфекционными событиями. Итак, дополнительные симптомы могут быть различные высыпания на коже, абдоминальные боли, боли в грудной клетке, костно-мышечные боли, поражение органа зрения. А какие же осложнения, ну и даже, может быть, не совсем верный термин осложнения, варианты поражения, каких органов и систем? На самом деле очень много разных вариантов, они зависят от той формы, с которой мы имеем дело. Это поражение центральной нервной системы, это поражение органов дыхания, это задержка полового созревания и бесплодия, особенно у женщин, это очень типичная история для пациенток с семейной морской лихорадкой из-за спаечного процесса в малом тазу. Это костно-мышечные симптомы, такие как мышечные боли, костно-мышечные боли, деформация костей, остеопороз, боли в суставах. Это воспалительные изменения в органы зрения, это uveitis, потеря зрения, потеря слуха, поражение сердца, печеночная недостаточность, гепатоспленомегалия, развитие миелоидозы. И вот этот, опять же, рецидивирующие перитониты, которые характерны для семейной морской лихорадки, приводят к спайкам в брюшной полости, к кишечной непроходимости, к задержке полового созревания. Ну и, конечно, аутовоспалительные заболевания, они очень похожи, да, они очень похожи на инфекционные события, да, и действительно, как это маски моногенных аутовоспалительных заболеваний, да, можем посмотреть на вот этот слайд, попытаться найти представителей животного мира, да, на самом деле мы видим, что это на самом деле как такая мимикрия. Действительно, многие пациенты очень похожи на инфекционных больных, что затрудняет своевременную постановку диагноза. Эти пациенты действительно очень часто получают ненужную антибактериальную терапию, госпитализацию в инфекционный стационар, дополнительную контаминацию инфекционными агентами и так далее. Итак, инфекционная маска, конечно же, это пневмонии, плевриты, асептические перитониты, менингиты, увеличение лимфатических узлов, повышение СОИЦа, реактивного белка. Действительно, пациенты чаще всего с аутовоспалительным заболеванием попадают в поле зрения инфекционистов, и действительно многие пациенты неоднократно госпитализируются в инфекционные стационары. Гастроэнтерологические маски – это боли в животе, диарея, тошнота, рвота, запор, гастроэзофагальная рефлюксная болезнь, воспалительные заболевания кишечника, гепатоспленомегалия, неврологическая, извините, маска, да, это головные боли, менингит, костно-мышечные боли, демиелинизирующие расстройства, поражение центральной нервной системы, почечная маска, конечно же, самая тяжелая, это амилоидоз почек, это бессимптомная протеинурия в ранних стадиях, потом нефротический синдром, потом амилоидоз, потом, собственно говоря, развитие хронической болезни почек. Иммунологическая маска, пациенты похожи на иммунодефициты, на хронические крапивницы, на первичные иммунодефициты, на васкулиты, на системную красную волчанку, на болезнь Бехчета. Дерматологические маски, различные сыпи, крапивницы, псориазоподобные высыпания, акне формные. И, конечно же, ревматологические маски, которые представлены костно-мышечными проявлениями, артритами, артралгиями, миозитами, миалгиями, острыми хроническими артритами, ревматоидным артритом, спондилоартритом, спондилартропатией. Ну и, конечно, другие маски включают в себя, мы уже поговорили, это хирургические истории в виде аппендицита, например, да, или спаечной болезни, это бесплодие у женщин с периодической болезнью, задержка развития, хроническое воспаление приводит к кардиоваскулярным событиям, атеросклерозу, инсульту, артериальной гипертензии, нарушению системы кровообращения, глазная симптоматика представлена увеитами, конъюнктивитами. Ну и 4 основных аутовоспалительных заболевания, я немножко о них расскажу, хотя сегодня у нас будут более подробные выступления наших иностранных спикеров. Это криоперин-ассоциированный периодический синдром или КАП-синдром, это синдром дефицита мевалонат-киназы или ХИТ-синдром, это семейная синоморская лихорадка и ТРАПС-синдром. Ну и сравнительная характеристика связана с тем, что разный тип наследования, мы уже с вами говорили, что семейная синоморская лихорадка имеет 2 типа наследования, рецессивный и доминантный, ХИТ-синдром имеет аутосомно-рецессивный, ТРАПС и КАП-синдромы аутосомно-доминантные. Частота встречаемости очень разная. Если мы будем говорить о распространенности патогенных аллелей, то в этнических группах частота встречаемости носительства до 1 на 5 человек, то есть это очень высокая частота. При этом ряд заболеваний являются очень редкими, да, и такие синдромы, как дефицит меланоткиназы, например, ТРАПС-синдром, КАП-синдром, встречаются с частотой от 1 на несколько сот тысяч до 1 на миллион. Разный возраст манифестации. И только для семейной синоморской лихорадки характерна определенная этническая характеристика, этнические группы. Если говорить о основном доминирующем симптоме, то для семейной синоморской лихорадки, конечно, являются абдоминальные атаки, сопровождающиеся эпизодами лихорадки. Для криоперин-ассоциированных синдромов это сыпи, уртикароподобные высыпания, уртикарий плюс температура, плюс лихорадка или уртикария плюс воспалительная активность. Для синдрома ТРАПС фактически сочетание лихорадки с болями в животе и уртикарными высыпаниями. Да, как будто бы ТРАПС-синдром вобрал в себя черты 2 предыдущих заболеваний, а синдром ХИТС, он очень необычный. Это пациенты, которые характеризуются очень ранним дебютом на 1-м году жизни, и эти пациенты характеризуются основными симптомами тем, что у них есть циклические эпизоды лихорадки продолжительностью примерно 1 неделя, встречается не с частотой маленьких детей от 1 раза в месяц, иногда даже несколько эпизодов, может быть, в месяц, и действительно очень вариабельный набор симптомов, это лимфоденопатия, абдоминальная симптоматика, рвоты, поносы, лихорадки, высыпания. Но вот лимфоденопатия и боли в животе являются такими доминирующими симптомами для этой группы заболеваний. Криоперин-ассоциированный периодический синдром – это группа, представлена 3 основными формами. Мягкая форма – семейный холодовой воспалительный синдром. Но по названию все понятно. Да? Есть семейный анамнез, доминантный тип наследования, есть есть крапивница, которая связана с переохлаждением. Крапивница плюс лихорадка. Поскольку доминантный тип наследования, очень часто многие родители считают, что у них есть крапивница, у детей есть крапивница, что это наследственная история, а то, что ребенок температурит, но уже часто болеет. Либо другая ситуация, когда крапивницу у температурящего ребенка все время пытаются связать с аллергической реакцией на какие-то антипиретики, да, сиропы, антибактериальные препараты. То есть получается каждый раз, как только ребенок температурит, его начинают лечить, получают крапивницу, считают, что это лекарственная аллергия. Синдром Макловелса более тяжелая форма, для нее характерна уже меньшая ассоциация с холодовыми факторами, да, действительно пациенты больше температурят, не всегда четкая привязка к холоду, ну и очень важный симптом – это нейросенсорная тугоухость, которая у этих пациентов появляется на втором десятилетии жизни. И самая тяжелая форма – это синдром Кинкана-Мид, хронический младенческий нервно-кожный артикулярный синдром или младенческое мультисистемное воспалительное заболевание. Ну и, конечно же, клинические особенности фенотипа вот здесь представлены. Здесь короткие атаки, здесь более продолжительные частые атаки, а здесь практически персистирующее воспаление, симптоматикой поражения центральной нервной системы, хроническим менингитом, отеком дискозрительных нервов, костными лицевыми дисморфиями, гипертрофической остеоартропатией таких пациентов. ТРАПС-синдром, периодический синдром, ассоциированный с рецепторами, с мутациями в рецепторе фактора некроза опухоли альфа, разная продолжительность приступа. Мягкие фенотипы – это частые, но короткие эпизоды. Большие тяжелые фенотипы – это длительные эпизоды от недели до 4 недель, которые имеют несколько эпизодов в год. Высыпание, обширное уртикарное высыпание, костно-мышечные боли, периорбитальный отек, всегда высокая лабораторная активность в момент приступа. И здесь мы видим как раз те самые крупные массивные уртикарные высыпания и динамику температурной кривой. Семейность, синеморская лихорадка, два типа наследования, доминантно рецессивный, обязательно этнос, это очень важно, и циклические эпизоды лихорадки с абдоминальными атаками, маленькие дети начинают с температуры, присоединяют абдоминальную симптоматику, ну и повышение лабораторной активности в момент приступа у таких пациентов. Семейная тиморская лихорадка, такой, в общем, классический тоже пример педиатрического заболевания. Большинство пациентов заболевают, да, еще в возрасте до 20 лет, и большая часть в возрасте до 10 лет. Этнос, нации, имеющие народы отношение к Средиземному морю. Но если говорить про нашу страну, то, конечно же, это весь Кавказ, да, это этнические армяне, азербайджанцы и все народы, населяющие Северный Кавказ. Это крымские татары. Частота встречаемости в этносах очень велика. Помните, говорил о том, что в ряде этносов, таких как этнические армяне, или крымские татары, или турки, частота патогенных вариантов носительства 1 на 5, 1 на 10. Поэтому частота болезни от 1 на 100 до 1 на 1000, в зависимости от, опять же, да, распространенности в конкретном регионе, близкородственности браков и так далее. Да. Поэтому мутации, исходно носила приспособительный характер. Гетерозиготы имели сильную иммунную систему, которая позволяла выжить во время пандемии чумы. И, собственно говоря, эти пациенты, имея сильную иммунную систему, не погибали от инфекций. Те, кто не имели, погибали чаще. Соответственно, формировалась такая прослойка людей с этими патогенными вариантами. Дальше они стали, соответственно, стали появляться либо мононациональные, да, либо браки на ограниченных территориях, либо близкородственные браки. Это стало приводить к тому, что стало появляться гомозиготы или компаунд-гетерозиготы, которые, собственно говоря, стали болеть, да. То есть вот так приспособительная история привела к болезни. Ну и если говорить о нашей стране, то основные, конечно же, это народы Кавказа, да, армяне составляют 91% из всех выявленных случаев семейной синеморской лихорадки, но в целом действительно это все равно привязка к южному региону. Ну и там, где есть большие диаспоры, соответственно, вероятность встречаемости этих пациентов достаточно высока. Мы считаем о том, что пациентов должно быть не меньше, чем 3000, но реальные цифры мы считаем о том, что вообще пациентов должно быть порядка 10 тысяч в нашей стране. Вот здесь представлены расчетное количество пациентов, да, с различными формами семейной синеморской лихорадки, поэтому понимаем, что у нас на сегодня очень большой процент, порядка 80% недовыявленных пациентов. Какие же клинические проявления семейной синеморской лихорадки? Итак, основным симптомом является лихорадка, продолжительностью от нескольких часов до 3 дней. Эти эпизоды лихорадки сопровождаются часто болями в животе, перитонит, реже болями в грудной клетке, не совсем часто настоящим артритом, больше костно-мышечные боли, и у части пациентов может быть рожистое или рожеподобное воспаление. Ну и, конечно, история такова, что вот эта вот лабораторная активность вместе с абдоминальной симптоматикой лихорадкой приводит очень часто к ошибочным диагнозам, и самые, конечно, большие проблемы связаны с неправильной установкой диагноза хирургического. Это острый аппендицит, это заболевание желудочно-кишечного тракта, поэтому пациенты получают необоснованное хирургическое лечение, пациенты, соответственно, получают и лапароскопию, аппендэктомию, опять же, перитониты плюс хирургия – это спаечная болезнь, соответственно, риски развития в последующем кишечной непроходимости, а у женщин проблемы с бесплодием. Ну, на втором месте это ревматические заболевания, по частоте, так скажем, ошибочных диагнозов, потому что, опять же, лихорадка, костно-мышечные симптомы трактуют пациента как артриты. Ну и еще раз, особенности, как не пропустить семейную симморскую лихорадку, конечно же, это воспаление, молодой возраст и этнос, это очень важно. И семейный анамнез, несмотря на то, что больше половины случаев все-таки заболевания с рецессивным типом наследования, но ввиду того, что заболевание очень высоко распространено, частота очень высока в этносах, то на самом деле нередкая история, когда в семье есть и больные, и бывает ситуация, когда один из родителей является больным, второй является гетерозиготным носителем, и часто в таких семьях вообще складывается ощущение, что тут доминантное наследование, даже при явном наследовании, рецессивном типе наследования. Многие пациенты, конечно же, имеют задержку постановки диагноза, потому что заболевания не очень частые, и врачи не очень хорошо, так скажем, осведомлены в большей своей массе о этой группе заболеваний. Ну и, конечно, многие пациенты имеют достаточно серьезную задержку в постановке диагноза от клиники до того, как найти своего доктора, выполнить генетическое тестирование, получить результат тестирования, ну и дальше назначение в терапии, и, что очень важно, наблюдение того специалиста, который является таргетным для конкретного пациента. Синдром ХИЦ или синдром дефицитной волноктиназы – самое необычное заболевание, потому что заболевание формально с точки зрения молекулярных основ – это заболевание, болезнь обмена, это нарушенный биосинтез холестерина, у пациентов мутации или патогенные варианты в гене НВК, но вот накапливаются продукты предшественники, у таких пациентов, и они запускают, активируют инфламмасому. Клиническая картина, эпизоды лихорадки, сыпь, автозный стоматит, лимфоденопатия, боли в животе, рвота, диарея, такие интенсивные высыпания. И характерно то, что пациенты начинают болеть очень-очень рано. Ну и мы говорим о том, что действительно проблема аутовоспаления связана с низким уровнем осведомленности врачей, похожесть симптомов с соматическими заболеваниями, с инфекционными заболеваниями. И, конечно, необходимо таким пациентам проводить молекулярно-генетическое тестирование. Итак, когда мы можем заподозрить моногенное аутовоспалительное заболевание? Если у человека есть эпизоды циклической лихорадки, длительные либо повторные, очень важно, сочетающие с высокой лабораторной активностью. При наличии дополнительных симптомов, что еще быстрее помогает поставить диагноз, такие как костно-мышечные симптомы, абдоминальные боли, кожные высыпания. Вообще цикличность и стереотипность характерна для этой группы пациентов, чтобы их заподозрить. Лабораторные тесты, опять же, самый важный поиск маркеров воспаления, когда в тот момент, когда происходит воспалительная активность, то есть в момент лихорадки, вне лихорадки, у этих пациентов может не быть измененных анализов крови, что достаточно легко пропустить. Но и на сегодня в Российской Федерации существует программа поддержки пациентов с наследственными аутовоспалительными заболеваниями. Соответственно, у нас есть в стране уже несколько лет работает проект «Горячая линия», который позволяет выполнять бесплатно генетические исследования пациентов с аутовоспалительными заболеваниями. Любой доктор имеет право позвонить по телефону на горячую линию, рассказать о своем пациенте, получить, соответственно, набор сухих пятен, сделать эти сухие пятна крови, отправиться, соответственно, в центр без поездки пациента, и выполнить генетическое исследование. Ну и, собственно говоря, вот так выглядит эта программа. Она работает для основных 4 моногенных аутовоспалительных заболеваний, позволяет поставить этот диагноз. Вот еще раз здесь представлен телефон горячей линии проекта, поэтому вы тоже можете все этим пользоваться. И, конечно же, работа этой программы привела к тому, что мы стали находить больше пациентов. Прирост выявляемости от 82% до 170% пациентов. А это, конечно, очень существенно, это очень важно, и мы стали больше выявлять, мы стали больше лечить, и, соответственно, это стало улучшать качество жизни пациента. Для поиска этих заболеваний были разработаны классификационные критерии европейской группы Еврофива, о которыми хочется сегодня тоже поговорить. Для синдрома ТРАПС или периодического синдрома, ассоциированного с рецепторными факторами некроза опухоли альфа, были разработаны критерии, содержащие данные молекулярно-генетического исследования. Итак, это подтверждающий генотип гена ТНФ РСФ1 альфа и хотя бы один из критериев. Это продолжительность атаки больше 7 дней, это миалгия, мигрирующая сыпь, переорбитальный отек или больные родственники. Что такое подтверждающий генотип? Это генотип, про который уже известно, что он был ассоциирован, для которого могли быть проведены функциональные исследования. Если же не подтверждающий генотип, так называемый генотип неизвестного значения, при наличии двух и более критериев, больной может быть отнесен к диагнозу ТРАПС-синдром. А вот клинические классификационные критерии, конечно, они присутствуют, но мое мнение, что это скорее критерии, которые требуют для отправления пациента на генетическую диагностику. Да? Я все-таки считаю, что диагноз должен быть поставлен при помощи генетического исследования. Криоперинассоциированный периодический синдром, гетерозиготные варианты в гене НЛРП3, хотя бы один из критериев, крапивница, покраснение глаз, нейросенсорная потеря слуха. Но, что важно, вот этот симптом нейросенсорной потери слуха, он происходит у пациента второго десятилетия жизни, то есть у ребенка первых 10, 12, 15 лет жизни этот симптом не работает. Не подтверждающий генотип – это гетерозиготы неясного значения, 2 и более критериев выше. И опять же, клинические классификационные критерии, с одной стороны, позволяют выявить пациента, кому необходимо генетическое исследование, с другой стороны, у этих пациентов есть другая проблема. До половины пациентов с клиникой КАПС могут не иметь мутации в гене НЛРП3, что связано с соматическим мозаицизмом. И тогда действительно в таких пациентов мы дополнительно проводим так называемый тест-блокатор интерлейкина-1. Опять же, если в момент приступа ввести анакиндру, это растворимый антагонист рецептора интерлейкин-1, он закрывает рецептор от молекулы интерлейкин-1 и не дает запускать каскад воспалительной реакции. Синдром дефицитной волноткиназы. Но здесь два патогенных варианта. Правда, бывает ситуация, когда второй вариант выявить не удается. Итак, два патогенных варианта и один хотя бы клинический вариант. Да? А варианты могут быть гомозиготы, компаунд гетерозиготы и дополнительные клинические симптомы, желудочно-кишечные симптомы, шейный лимфоденит, автозный стоматит. А вот опять же, клинические классификационные критерии, они скорее позволяют выявить того пациента, кого надо отправить на генетическую диагностику, потому что, конечно, клинически поставить диагноз весьма и весьма сложно. Ну и семейная синеморская лихорадка. Опять же, подтверждающий генотип гена МЕФ – это два патогенных варианта в гене МЕФ, один из которых обязательно является вариантом 10-го экзона, и тогда действительно должна быть один клинический симптом, либо лихорадка, либо артрит, либо боли в груди, либо боли в животе. Неподтверждающий генотип. Что такое неподтверждающий генотип? Это либо гетерозиготы, которые, как мы понимаем, могут болеть, либо это гомозиготы, компаунд гомозиготы не по 10-му аллелю. Ну и, соответственно, тогда надо иметь два и более критериев. Ну и клинические критерии, опять же, все-таки я считаю, что это те критерии, которые мы не должны на их основании ставить диагноз, а мы должны на их основании понять, с каким пациентом мы имеем дело, и отправить этого пациента на генетическую диагностику. Терапия аутовоспалительных заболеваний. Но в отношении лекарственной терапии здесь все относительно просто. Мягкие формы. Мы принимаем антипиретики, нестероидные противовоспалительные препараты. Для части пациентов, таких как пациенты с ХИТ-синдромом, ТРАПС-синдромом, можем давать короткие курсы кортикостероидов от 1 до нескольких дней. Мы стараемся не давать кортикостероиды пациентам с семейной синеморской лихорадкой, потому что приступы обрываются хорошо, но больные могут становиться гормонозависимыми. Для семейной синеморской лихорадки есть основной базисный препарат. Это колхицин, который должен приниматься постоянно. Он профилактирует не только системное воспаление, не только приступы, но, конечно же, риск развития амилоидоза. Ну и для пациентов, которым не подходят эти виды лечения, либо не работают, либо частые приступы, либо не хватает эффекта колхицина при семейной синеморской лихорадке, конечно же, мы используем блокатор интерлейкина-1. Вы помните, что когда мы говорили о патогенезе заболевания, да, то интерлейкин-1 является ключевой молекулой во всей этой истории. Ну и и контроль эффективности, конечно же, это лабораторные тесты, это оценка органных функций, да, и, собственно говоря, контроль производится с частотой, ну, в зависимости от того, какой препарат мы используем, но оптимальный вариант контролировать не реже, чем 1 раз в 3, максимум 6 месяцев. Ну и, конечно же, поскольку заболевания, да, такие относятся к понятию масок, имеют много различных проявлений, то для этой группы заболеваний, конечно же, очень необходим междисциплинарный подход разных специалистов. Соответственно, часть специалистов – это специалисты, которые вовлечены в диагностику, часть специалистов, которые вовлечены в введение пациентов. И, конечно же, такими ключевыми специалистами являются педиатр, инфекционист, иммунолог, аллерголог, поскольку, опять же, лихорадка, лабораторная активность, пациенты похожи на инфекцию, пациенты похожи на иммунологическую дисфункцию. Эти специалисты являются наиболее частыми. Генетик позволяет выполнить либо молекулярную диагностику, либо помочь в семейном, соответственно, генетическом, да, медико-генетическом консультировании. Ревматолог помогает при костно-мышечных симптомах, либо ревматолог нужен в тех ситуациях, когда необходимо помочь в терапии, потому что действительно препараты, которые используются в аутовоспалении, это препараты, которые исходно применялись и применяются у пациентов с ревматическими заболеваниями. Так, извините, слайд не переключается. Вот. Ну и в заключении, да, аутовоспалительные заболевания – это редкие заболевания, часть из которых, да, с известными моногенными механизмами, с известной молекулярной природой, для которых более-менее имеются накопленные знания по особенностям течения, по особенностям исходов, по ответу на терапию, но история, конечно же, расширяется, больных много, и, конечно, врачи разных специальностей должны быть готовы к встрече с такими пациентами. Они не совсем уж являются редкими, но уж точно не все из них являются ультраредкими. Дорогие коллеги, большое спасибо за внимание. Ну, моя часть уже такая, скажем, заканчивается, русскоязычная, и дальше мы передаем слово уже нашим иностранным спикерам, которые будут подробно рассказывать о основных аспектах аутовоспалительных заболеваний, оперируясь на свой опыт, да, и на, конечно же, литературные данные. Большое спасибо.
Be on pathogenesis of FMF, how to diagnose and how to treat FMF in our pediatric rheumatology clinics. As we all know, autoinflammatory disease refer to problems with the innate immune system's reactions. When the immune cells became activated, it causes damage to host cells. Neutrophils and macrophages are the main players of autoinflammation. Familial midterm fever is the most common autoinflammatory disease, and it is characterized by recurrent attacks of fever and serositis and elevated acute phase reactants. Autosomal recessive inheritance is seen, and there is history of recurrent fever. The disease is quite common among populations surrounding the Mediterranean Sea, like Turkish, Armenian, Middle Eastern, North African, Jewish, and Arab descent. In Turkey, there is a very high prevalence between 1 to 400 and 1 to 100, and the high frequency of MFVV mutations among Ashkenazi Jews and Turks may be explained with a selective advantage against Yersinia pestis. But over the years, many patients have been diagnosed as FMF all around the world. Although FMF is one of the well-known autoinflammatory diseases, the investigations in pathogenesis and genetics of FMF points to a more complex disease. Since discovery of MFBV gene in 1997, a new chapter has started. FMF is caused by mutation in the MEFV gene coding for pyrin. Pyrin is a protein used to assemble the pyrin inflammasome in white blood cells and plays an important role in the innate immune system. Over the past 2 decades, great progress has been made, especially on pathogenic manifestations underlying pyrin inflammasome. Once the pyrin inflammasome is activated, it causes assembling of multimolecular pyrin inflammasome that promotes the cleavage of pro-caspase pair. After activated, active caspase also cleaves pro-IL-1 beta to its active form IL-1 beta. One of the articles pointing to pyrin activation is about steroid hormones. Pyrin activation proceeds in 2 steps. First step is dephosphorylation and second step is still poorly understood. Magnotti and his colleagues used a chemical screen to identify pyrin inflammasome activators acting primarily on step 2, and they have found that etoconolone and pregnenolone is both hormones can activate step 2. FMF patients display a moderate increase in steroid catabolite-induced inflammasome responses that could contribute to inflammatory flares and be dependent on the MEF genotype, and this may be the cause of menstruation triggering FMF attacks in our patients. FMF usually presents in late childhood or adolescence, with most patients having at least one attack before age 20 years. Episodes typically last between 12 and 72 hours and involve chest, abdominal, skin and joint symptoms, and of course fever. Time between attacks varies and is currently unclear what may trigger symptoms. However, it is hypothesized that stress, exercise, infections and menstruation can trigger attacks in these patients. Symptoms may begin with fever as the only clinically significant feature in children, who over time develop progressively more signs and symptoms. Abdominal pain is the most common system affected after fever, which can easily be misidentified as an acute abdomen with appendicitis. Also, arthritis and arthralgia, chest pain can be seen during attacks. Most cutaneous finding is erysipelas-like erythema in 12 to 15% of patients, and also in these patients, polyarteritis nodosa and IgA vasculitis is commonly seen. There may be differences in clinical presentations between regions. Among Japanese patients, the frequency of fever and peritonitis is relatively low, headache is much common, attack duration is longer, and disease usually responds to a low dose of cortisone. And also this is a study we have made with Mikael, and when we compare Crimean and Turkish patients, age and gender distribution, the frequency of cortisone resistance, and cortisone intolerance were similar. The duration of attack was shorter in Turkish patients, but chest pain was more frequent, but arthralgia, arthritis, and erysipelas rash were more common in Crimean Tatar patients. It is important to diagnose FMF patients. The diagnosis is made on the basis of clinical findings and ethnic background and/or family history. During FMF episodes, laboratory findings show elevation acute fast reactants such as erythrosedimentation rate, C-reactive protein level, and serum amyloid A. Genetic testing can often be helpful in identifying the exact mutation and supporting diagnosis. Turkish pediatric criteria can be used to diagnose FMF. Fever, abdominal pain, chest pain, arthritis, and family history of FMF can be used as a criterion. In 2019, Eurofever suggested a set of criteria that included genetic testing. But the important question is when to perform genetic testing in these patients. If a patient has multi-ethnic origin and meets Eurofever clinical criteria, we should perform genetic tests. But this decision is largely affected by the country of origin. In our country, we perform MFVV analysis also in patients with recurrent non-infectious febrile episodes, individuals with elevated acute phase reactants in the absence of infections, and patients with atypical cause of rheumatic disease. To date, more than 385 MEFV variants have been reported. A panel of experts have recommended to screen these variants. Pathogenic variants mostly exantone mutations. These are variants of unknown significance and normal variants. We should consider that R202Q mutation is a normal variant. If a patient has two pathogenic variants, we can confirm the diagnosis of FMF. If one pathogenic variant and one uncertain or variants of unknown significance variant, we can make therapeutic tests with colchicine. If it is positive, we can consider FMF diagnosis until proven otherwise. If it is negative, we should look for a different diagnosis. If there is no pathogenic variant detected, we should also again look for a different diagnosis. Patients with FMF phenotype but with only one pathogenic mutation have been described all over the world. Can MF mutation be a significant risk factor for the symptoms or the phenotype of FMF? So for the heterozygote patients in our clinic, it is also important to consider acute phase reactants and serum amyloid A level between attacks to consider treatment. Colchicine is the mainstay of treatment since 1974. And treatment with colchicine should be started as soon as possible as the first line of treatment, and the ultimate goal of treatment in FMF is to reach complete control of unprovoked attacks, prevent sequelae of inflammation amyloidosis, and prevent subclinical inflammation in between attacks. According to regular recommendations, FMF should be diagnosed and initially treated by a physician with experience in FMF. We must start colchicine treatment with a low dose and increase the dose according to the weight, age, and control achievement of the disease. The patient's response, tolerance of the patients with amyloidosis or very high disease activity may start with higher doses. Dosing can be single or divided doses depending on tolerance. We should divide if diarrhea or related abdominal pain occurs, but single dose is important in keeping patient compliance, especially in adolescent patients. It is important to adjust the dose based on disease activity, with the adjustment of maximum dose for children depending on age and weight. Inability to mount colchicine dose to a prophylactic level due to adverse events. Usually diarrhea is called colchicine intolerance. What are the adverse events? Diarrhea and abdominal soreness is the most common. Rarely neutropenia, myopathy, neuropathy, and hair loss may take place. Liver toxicity in an ordinary dose, most liver enzyme abnormalities. Colchicine toxicity is a serious complication and should be adequately suspected and prevented in these patients. We don't recommend exceeding the recommended dose. Colchicine is metabolized by liver and kidney, so in liver or renal failure patients, those adjustments should take place. And the use of macrolides in children and cyclosporin in transplanted patients warrants special caution, and the primary physician zones. Potential drug-drug interactions and colchicine may increase its blood levels by 200 to 300%. So we should warn our patients to stop colchicine use if she or he has to use macrolide antibiotics for their infectious disease. Familial Mediterranean fever in heterozygotes is a very important issue. This study shows that 33 patients who carried a single MAC mutations in the heterozygote states have been followed up at least 3 years, and shown that during follow-up, heterozygotes had a milder disease course compared to homozygotes and were less prone than homozygotes to experience new clinical signs of FMF. At puberty, clinical signs of FMF completely disappeared in 5 of 18 heterozygotes, allowing them to discontinue colchicine without recurrence of symptoms or increases in inflammatory marker levels. So can we discontinue colchicine in symptomatic carriers for MF variants? Yes, in our clinic, we have shown that we can stop colchicine treatment, especially if they are asymptomatic more than 3 years in patients with heterozygote mutations. What is colchicine resistance? For a patient receiving the maximum tolerated dose of colchicine, resistant to colchicine is defined as ongoing disease activity or persistently elevated CRP or SAA in between attacks in the absence of any other plausible explanation. The proposed newly developed treatment targets incorporate multidimensional aspects of disease presentations and allow the definition of different disease activity stages like minimal disease activity, mild disease activity, moderate and severe disease activity. Apart from this, they show the importance of school work days missed due to FMF, chronic sequelae, physician global assessment, and patient global assessment in patients while evaluating patients with colchicine resistance. Can we predict colchicine resistance? Age at symptom onset before 3 years, attack frequency before diagnosis and more than one attack per month, arthritis, chest pain, and exon 10 mutations can be risk factors to predict colchicine resistance in FMF patients. More recently, and following the finding that FMF activity is mediated by the pro-inflammatory cytokine IL-1 beta, IL-1 blockers have been proposed as a possible treatment for colchicine resistant FMF. Accordingly, the IL-1 beta antibody canakinumab was the first IL-1 blocker approved for treatment of FMF. A little later, anakinra, the first synthesized IL-1 blocker and the first to be released to the market for treatment of a variety of inflammatory disorders, have been started to use in colchicine-resistant FMF patients. And it has been shown that both anakinra and canakinumab has been efficient in these patients and safely can be used in our patients with colchicine-resistant FMF. Anakinra can be used also in unsolved leg pain or arthritis, amyloidosis, renal transplantation patients, protracted fibromyalgia, pericarditis, on-demand treatment for acute attacks, temporary replacement of colchicine, and pregnancy. According to treat target strategies, it is also emphasized to dose reduction of biologics in these patients. In our cohort, we have shown that we can discontinue canakinumab in 18 patients at the end of 18 months. And after a median follow-up of 1 year, 2 patients had a relapse and has to start canakinumab again. At first, we give canakinumab for 6 months, and then we expand the dose intervals. And at the end of the 18 months, if there is no attacks and serum amyloid A level is normal, we discontinue canakinumab in these patients. Treatment of attacks are also important in these patients. The first-line therapy should combine analgesics and antipyretics with non-steroidal anti-inflammatory drugs. Parenteral therapy may sometimes be necessary, but we have never used it. If pain passes level 2 or 2, analgesics may be required. On-demand anakinra can be used. There are some case reports in the literature about this, but we never recommend the increase in dosage of colchicine during the attacks. Vaccination is also very important in these patients. Before starting biologic therapies, vaccination should be completed because the initiation of biotherapy in FMF is not an emergency. All vaccinations, including HPV, should be checked. Catch-up vaccination is recommended. Pneumococcal vaccination is recommended. Varicella vaccination for naive patients with 2 doses are recommended, and also annual influenza vaccinations are recommended in these patients. Amyloidosis is one of the leading causes of mortality in FF patients and occurs in several organs, including the gastrointestinal tract, lungs, and kidneys. But there are other clinical sequelae of chronic inflammation in FMF, like normocystic normochromic anemia, splenomegaly, graphic retardation in children, decreased bone density, impaired health-related quality of life, depression, and anxiety. And risk factors for AA amyloidosis is past family history of amyloidosis, male sex, and homozygosity in the M694V mutation. Anakinra and canakinumab are effective in both FMF amyloidosis and after renal transplantation. It has also been shown that treatment with anti-IL-1 agents in children with FMF may potentiate long-term growth in these children. Health-related quality of life means perceptions of the position in life in the context of their cultural and value systems in which they live, and in relation to their goals, expectations, and standards. Most often, FMF has been shown to affect patients and their families, personal relationships, school situation, employment, and social activities. In a study with school-age children with familial maternal fever, it has been shown that physical, emotional, and school function is lower in FMF patients, especially in adolescents. The most relevant unmet needs are school, healthcare system, and public institutions in these children with FMF. And also this figure shows the areas of emotional burden living with anti-inflammatory disease, like fear of failure, socioeconomic impact of disease, social isolation, feeling of being different, guilt of transmitting a genetic disease, social disbeliefs in specific needs, support and protection, loneliness, sadness. It is important to think about health-related quality of life in these patients to help them more efficiently. A survey was developed in collaboration between the FMF and AIDS Global Association and the Erlangen Center for Pediatric Systemic Autoinflammatory Disease. FMF is a complex autoinflammatory disease, and despite the global use of colchicine, it does not provide 100% symptom relief for all patients. Also, IL-1 inhibitors used with or without colchicine can't provide 100% symptom relief for all patients. Again, this points to health-related quality issues when treating our patients with FMF. When treating our patients, we should collaborate with our psychiatrists, physiotherapists, pediatrics, family physicians, maybe teachers, maybe friends of the patients, family of the patients, so that they have a good life with happiness and without attacks. This is the end of my speech. Thank you very much for your attentions. If you have any questions, you can find my email address. Please don't hesitate to ask me. I wish you a good congress and enjoy your time. Thank you very much again for inviting me.
Hello, this is Marco Gattorno speaking. It's a great pleasure to present this data on this condition that is of interest. Of course, it's a great pity that I cannot be physically with you, our colleague. We are all dealing with children with disease, and that is something that it's always the most important thing for all of us, despite all the difficulties that we are facing during these very hard times. So for this reason, it's a great pleasure to meet you and talk about on this subject today in this very important meeting you have in St. Petersburg. These are my disclosure. You know very well about inherited autoinflammatory disease, that monogenic disease caused by mutation of gene involved in the innate immune response, leading to sterile infection. The first gene was identified in 1997. There was a gene of FMF, and variants with the classical autoimmune disease, as you know very well, they do not have class 2 HLA association, and they do not have pathogenic antibodies or antigen-specific T cells. As you know very well, the first disease related to periodic fever, monogenic disease, was familiar Mediterranean fever that was discovered in 1997 and is highly prevalent in some population, especially between Jews, Turks, Armenians, and Arabs. At the beginning of the story, there was a number of clinical features that were related to a possible genetic disease because they were an ethnic background or because they have a family history. At the end of the last century, due to the possibility of positional cloning, this at that time new technique studying big families or a relevant number of patients was possible to identify the genes that were associated with the most prevalent and important recurrent fever at the beginning of the story of the autoinflammatory disease that was FMF, mevalonate kinase deficiency, TRAPS, and familiar cold autoinflammatory syndrome and Muckle-Wells syndrome. These were the classical periodic fever that we can define as the monogenic one, the classical monogenic one, especially FMF, mevalonate kinase deficiency, and TRAPS. But as you know very well, beside monogenic disease, there are some multifactorial disease that in which the most prevalent, even in the pediatric population for sure, is the so-called PFAP, in which the patients have this prevalence involvement of the tonsils with apoptosis and lymph nodes, and in a condition that is not genetic and is for sure multifactorial. What is SURF? After visiting children with recurrent fever since 20 years now, more than 20 years now, I got in contact with patients like Luca here, that at the age of 3 years start to have recurrent fever with no strict periodicity, duration 3-4 days, frequency almost monthly. Often he has arthralgia, myalgia, abdominal pain. Sometimes he has some erythematous pharyngitis, but just very seldom, and he has a quite good response to steroids. Of course, we cannot interact, but the possible approach is, okay, it is FMF, and I will start with colchicine. Indeed, we are in Italy, and there are relevant number of FMF, even if mainly in the south of Italy, or it's a PFAP because I have just some tonsillitis, so I will keep on with follow-up and steroid on demand. Or the possible choice is, no, I want to have more information, and I would like to have genetic analysis for this patient. Fourth point is in an undifferentiated recurrent fever, I will keep the follow-up. I would like you to think about what you think about these possible answers. And I have to say that I will bet for answer number 3. Question and answer number 3. So we go to genetic analysis, and we did a whole exome sequencing with in silico panel for 56 genes associated with recurrent fever, not with all autoinflammatory disease, but just with recurrent fever. But this panels was not informative. So we have in our clinical activity a lot of these patients like Luca. And we were very interested to this kind of patient with undifferentiated autoinflammatory disease. Some years ago, we studied this patient that have at least 1 year of follow-up, in which there was followed in our center for at least 1 year, and in which we would like to know, we were aimed to know if a panel of 41 genes was able to provide new diagnosis. Most of them were recurrent fever after exclusion of PFAP. You can see here 86% of this undefined autoinflammatory disease has a classical recurrent fever, like in the case of Luca. Using this panel, as in the case of Luca, unfortunately, in very few patients we were able to identify a gene and a final diagnosis. So we were intrigued about this special group of recurrent fever that have a completely different phenotype in respect to PFAPA, and they respond very well to colchicine. And for us, this group of patients was a distinct group, as we see in our clinical practice, that we like to define as syndrome of undifferentiated recurrent fever, SIRF. This is not a name that we did, but was the name proposed by our friend in San Diego, Al Hoffman and Lori Broderick. We also study the characteristic of undefined patient in autoinflammatory disease in the Eurofever registry some years ago, together with Jos Frankel and Ninken Terhar. And it was clear that they have very few manifestations of PFAPA, and those with recurrent fever, again, have much more abdominal pain, arthralgia, and myalgia. Again, there was a good response to colchicine, and also in those that have treated with anakinra, we have also a complete and partial response also to anti-1 blockers. It was very similar to FMF. Riccardo Papa in our group 2 years ago tried to make a revision of all the papers that were related to patient with recurrent undifferentiated fever, and he collected the data from the literature of almost 500 patients from 5 studies. And again, fever, fatigue, malaise, arthralgia, abdominal pain, myalgia were the most prevalent manifestation. So we decided to follow this group of patients that we see since many years ago, group patient like Luca, and to gather together the experience of Gaslini Institute. So we were quite strict. We start from 108 patients with undefined recurrent fever, and so of course we exclude those in which we were not with we didn't have follow-up, and we exclude all the patients that have some variant also of unknown significance, so they were just negative patients, and also we exclude those that fulfill the Eurofever PFAPA criteria. So at that moment, from 100 patients, we selected 50 patients with SIRF. And we analyzed this patient. You can see the median age, the age of first visit, and duration of follow-up. That was a median duration of 3 years, but there was some patient that we followed since for up to 10 years. All the patients have molecular analysis, and most of the patients, as you can see here, have a big panel, a 40 patient panel with NGS, and the way they come out to be negative. As in the literature review done by Riccardo Papa, we observed that arthralgia, abdominal pain, and myalgia were the most prevalent condition. Some patients have also clinical features of PFAPA. Most of them have seldom these clinical features and only one clinical manifestation, so only erythematous tonsillitis or only aphthous stomatitis. The treatment was quite important because all the only 2 patients were still treated with steroid on demand. 10 of these patients during their disease course, maybe those that have some tonsillitis, perform tonsillectomy, and it's very important that none of them have a resolution after tonsillectomy. The colchicine was used in 48 patients with mean duration of 2 years and 4 months. And the response to colchicine was quite good. 64% have a complete response, so absence of any fever episode. 20% of the patients have a partial response. That means a reduction of at least 50% of fever episodes, so a substantial response, and the median reduction was 73%. So and there was just 16% of the patient that was resistant to colchicine. What was quite interesting, this is quite, in my opinion, intriguing, we made also a univariate analysis to see which was the criteria to predict the absence of response, and the generalized lymphadenopathy, and also in a way exudative tonsillitis were those that were related to a lack of response to colchicine. This is quite interesting. What is quite interesting that again most of the patients were still on colchicine, and that 14 patients withdraw colchicine because of complete response, but 13 of them display a flare, and so they have to restart colchicine with again a good response. That means that in this patient the use of colchicine is important. So it's possible that indeed after many years of consultation of children with recurrent fever, and also this data coming from the literature and from our direct experience in a tertiary center of autoinflammatory disease, we could also think about another possible group of patients with recurrent fever or children with recurrent fever that we like to call SURF. Is SURF an homogeneous and distinct condition? This is the point. Maybe we have some data, they are in line now, because we have data in the literature, and they seems to be, of course, we understood that is a subset of patient with recurrent fever after a careful exclusion of hereditary recurrent fever and PFAPA. All the data seems that they have an homogeneous clinical features because they have arthralgia, abdominal pain, myalgia, and this is quite persistent in all the series that we have observed. And again, there is an homogeneous response to treatment. So, however, there are still some aspects in which that have been to define, to really think that SURF is an homogeneous condition. Are there novel genes? Maybe there is a new genes that are related to this patient with undefined recurrent fever, and so maybe we didn't look carefully to all the possible genes. This is or there are new genes that are not already recognized. Is there an homogeneous pathogenesis for this condition respect to the other recurrent fever? And which is can we think about some classification criteria as we did for recurrent fever, other recurrent fever? Okay, let's go for novel genes. And for the novel genes, I would like to tell you about the story of Marco that we follow with our colleague in Bologna. And Marco has an onset of 14 months with recurrent fever with a variable periodicity, 2-5 days. Sometimes he has pharyngeal hyperemia, lateral cervical lymphadenopathy, but sometimes he has also arthralgia, diarrhea, abdominal pain, macular papular rash. So it seems not to be a classical PFAPA. He made the NGS panel, which was negative. So we thought that also Marco could be a possible SURF. However, he performed a trial with colchicine for 6 months with no response. We also proposed to the patient a trial with anakinra, but the parents want to wait. In the meanwhile, that was October 2020, at that time, we sent the trio for exome sequencing at NIH by Ivona Xantievich and Massimo Gadina. In the following years, I have to say, it started to have a worsening on the clinical picture, with frequent febrile episodes, worsening of gastrointestinal symptom with the abdominal pain and rectal tenesmus, worsening of cutaneous system with this pustular rash in the folds, you can see here, and also some perianal ulcers. The colonoscopy performed ulceration of the level of transverse colon. As you can see, these patients do not have the typical features that we observe in Luca. The feature completely changed during the disease course. It didn't respond to colchicine, and indeed, in the meanwhile, after 2 years more or less, a report from NIH arrived, and indeed, this patient was heterozygous for RILA. RILA was a relay haploinsufficiency. This is an autosomic abdominal chronic mucocutaneous ulceration. And this is another condition that can present with recurrent fever. So the message here is, okay, we have to be sure that your patient is not indeed a new autoinflammatory disease, because the new autoinflammatory disease are coming. In this patient, the anti-TNF treatment was really important and had a very good clinical response. So the concept here is the autoinflammatory disease that we start with few diseases is a spectrum of disease that is expanding a lot. In the last report of the Union of Immunological Society, the autoinflammatory disease, this group of disease, were those that increase with a higher number of new diseases in the last 3 years, with an increase of 10% to 5%. And if you see here the dynamic of the evolution of the search of new genes and the finding of new genes and new disease in autoinflammatory disease after the NGS era, you can see here the huge amount of new conditions that are now gathering in the context of autoinflammatory disease. This is rather impressive. And so, yeah, we have really to think that that could be other genes in patients with recurrent fever, because some of these conditions can present with recurrent fever. Of course, the most prevalent and most frequent are FMF, mevalonate kinase deficiency, and TRAPS, but there are other conditions. So it's important to exclude. So there are another genes in this group of patients we've served. This is possible. What in our plan, what we are doing now, thanks to an European grant, we would like to have a whole genome sequencing in all served patients that we are studying, just to understand really if there are some genes that has not been found by the different panels. And that's also is the reason why we leave in our clinical practice the use of NGS panel, but we now use just whole exome sequencing, and then we put some in silico panels that are 56 genes just for recurrent fever, or 157 genes for autoinflammatory disease and immune dysregulation. And of course, you can make pass from one in silico panel to another in silico panels. And this is the most important things in this patient with undefined autoinflammatory disease, even if not recurrent fever. Every 6 months, we check again, thanks to the bioinformatic analysis, if maybe this condition, this patient have mutation in new genes that has been found. This is very important when we follow patient with undefined recurrent fever. And which is impact of the variants of unknown significance. As you remember, in our study in the Gaslini Institute, we let's say exclude all the patients that have variant of unknown region of different genes, MEF or TRAPS, for example. Because we want to be sure to have a very, very homogeneous group of patients without the incidence of our variants. And indeed, I think it's quite interesting to see this paper that we published again with Eurofever very recently, in which again with the group of Jos Frankel, and we analyzed the patient that have a variant, the typical variant of unknown region of TRAPS, of TNF receptor, that is R92Q. You know, there is a lot of debate, is R92Q a TRAPS, or if more related is, because the pathogenicity of this variant is very, very debated. And what was quite interesting that, as you can see here, we follow a relevant number of patients with this variant, 77 patients, classical TRAPS patient, pre-FAPA patient, as you can see, and also patient with undefined recurrent fever. You can see the number here. What is quite interesting, there were 60 patients in the Eurofever registry. What is quite interesting to see here that we compare the clinical manifestation of this R92Q patient with the classical TRAPS, PFAPA, and SERV patient. You can see here that the R92Q was completely different for many manifestation with the classical TRAPS, those with pathogenic mutation, but also with PFAPA. You can see here many clinical difference, but they were absolutely similar to SERV. So even patients with recurrent fever that are carrying R92Q variant have the clinical feature very similar to SERV patient. And indeed, that is another important point. Maybe you know that this patient with R92Q variant have a very good response to colchicine. So it's possible that is in this patient they are much more related to a SERV-like manifestation in which R92Q is not so relevant, and in fact the treatment of choice for this patient is colchicine. So this is quite interesting in my opinion. So we have still a lot to do in genetics, even if it's quite possible that SERV could be a multifactorial disease, not properly a genetic disease like PFAPA. So maybe some of patients, like in case of Marco, can have a new monogenic disease, or that it's possible, we have to check. But it's also possible they can have a different, a multifactorial condition. The point, very important, is also if they have an homogeneous pathogenesis. And we were intrigued to study, of course, this condition, also for the mechanistic point of view. Due to the fact that these patients respond quite well to colchicine, you know, colchicine is able to interact with the pyrine inflammasome at the level of GTPase ROA, and also at the level of the phosphorylated site of pyrine. So colchicine is a stabilizer of the cytoskeleton and stabilizer of pyrine inflammasome. So it's also important to know that since these patients respond quite well to colchicine, it was important to study the pyrine inflammasome. And there are two different stimulants that we can study on the primary cells of the patient with the clostridial difficile toxin, because of the toxin that are inactivating GTPase, or the kinase inhibitors UCN01. We have two different readouts that were the ASC-SPEC formation, as you can see, and also the secretion of IL-1. I show you here the data coming from the ASC-SPEC formation, and I tell you that they are very consistent with IL-1 secretion. What is quite interesting that when you stimulate this patient with clostridioides TCDA, and the behavior of FMF patient in respect to control is quite different. What is important to say that for TCDA, the control have a good response to respond to the use of to these stimulants, and is very well controlled by colchicine. UCN is that is inhibitor of this kinases do not respond in patient with in control, and the only patient that respond to UCN is FMF. You can see here. When we look to this patient, and what we observe that the patient with the use of kinase inhibitors is completely different from SIRF for FMF. In PFAPA, SIRF, only patients with FMF are able to respond to these kinase inhibitors. And so SIRF patients are completely different from FMF. When we use clostridiol difficile, what we observe here is that FMF have this very strange phenomena in which when we treat with colchicine, they are not able to reduce the ASC expression. All the controls, the SIRF patient and the PFAPA patient have this phenomenon, and only FMF. So again, SIRF were completely different from FMF. But when we look carefully to the stimulation with this stimulus, you can see here this red spot. These are SIRF patients untreated, without any treatment, as all PFAPA patients. And you can see here very well that untreated patients have a very strange low response to these stimuli. That was normal in normal individuals, in PFAPA, in FMF, but was depressed in untreated patients and were corrected by the colchicine treatment, as you can see here. This is quite interesting and was confirmed by the fact that the RO GTPase just in SIRF patients have a lack of activation in respect to healthy individuals and PFAP. So this is quite unique. And SIRF patients that respond well to colchicine seems to have a behavior of the pyrin inflammasome that is completely different from FMF and from PFAP. So they seems to have a homogeneous pathogenesis that involved the inflammasome, the pyrin inflammasome. Last point, because we try to understand if we can analyze some classification criteria for PFAPA. Maybe you know that we performed some years ago some classification criteria for recurrent fevers, and in this process, together with a lot of colleagues, geneticists, and the clinician, we validated a number of patients with FMF, IgG, TRAPS, SIR, and PFAPA. We had in this patient the 60 patients from the Gaslini cohort. It was quite interesting that we make a training and validation set and the two different approaches with the Chisholm tree and logistic regression. And and just to show these data that are not already published, the use of the Chisholm tree with the use of genetic analysis was able to identify 94% of the patient with SIRF, so a negative genetic analysis with the absence of erythematous tonsillitis was able to identify patient with a very good ROC curve. This is quite easy with the genetic analysis. But it's quite also interesting that we observe also a possible classification evidence-based decision tree with some clinical features, also without the genetic analysis, or while we are waiting for genetic analysis. That are the absence of trigger. In these patients do not have triggers usually. The absence of cervical lymph nodes, that you know is a negative factor for SIRF. The absence of family history, that is quite interesting. Patients usually do not have a family history, while PFAPA patients have family history. And the presence of myalgia seems to be quite specific for SIRF, 72%. Of course, the ROC curve was not that high, but however, considering that is not with genetic analysis, I think it's quite interesting. Future perspective and conclusion. So it's possible that when we analyze these patients with undefined autoinflammatory disease and also undefined recurrent fever with NGS, it's possible that we increase the number of classical monogenic autoinflammatory disease or immune dysregulation. But also it's also possible that using next generation sequencing, we cannot and also whole genome sequencing, we will not find any genes, and that SIRF can be considered, like PFAP and other conditions, a multifactorial autoinflammatory disease. This is quite possible. What we are doing now in a European project is try to understand this condition of undefined autoinflammatory disease, looking on phenotype, functional test, and obviously different omics with artificial intelligence to see how to cluster this patient with undefined recurrent fever in respect to other already known, if they use the same pathway or the same genes or the same network of genes, or if and proteins, or if they are behaving in a original way. So in conclusion, a relevant number of patients do not fulfill with recurrent fever, do not fulfill the PFAPA criteria, and are negative for genes for hereditary recurrent fever. A subgroup of these patients have an homogeneous phenotype and a general good response to colchicine. We love to call this new group as an undifferentiated recurrent fever, SIRF. We provide the first pathogenic insight on this condition. Of course, we need further evidences, including an extensive genetic analysis of the patient, as I told you. But however, it's possible that we can have, this could be a new multifactorial recurrent fever. Of course, we need a common classification criteria for future study, just to be sure that we are studying the same patient. Okay, I would like to thank all the people in Gaslini Institute in Genoa that are studying with me since many, many years, this patient with autoinflammatory disease. And of course, so I want to thank you, Mikhail, for the kind invitation, and all you that are attending the meeting, and God bless us all. Thank you very much indeed, and thank you.
Dear colleagues, dear friends, thank you very much for your kind invitation. I would like to present this presentation. Have a nice day. As you know, PFAPA syndrome is autoinflammatory condition commonly seen in childhood, unproven genetic inheritance characterized by recurrent fever. Together with familial Mediterranean fever, the most common recurrent fever in Turkey should be considered differential diagnosis of patients under the age of 5, which complains with recurrence. PFAPA syndrome is characterized by recurrent attacks of fever with sudden onset, after stomatitis, pharyngitis, and cervical lymphadenopathy. Patients have mental and motor development appropriate for the age. Most common among patients, all the patients under the 5 years. Fever with sudden onset, generally unresponsive to antibiotics and antipyretics, mostly upper than 39 degrees. Patients in a good general condition, despite the high fever, significant for differential diagnosis of infection. PFAPA syndrome can also observed in the patients. Most important clinical findings is fever. Fever spontaneously decreased in 3 or 5 days. Fever decreased in 3 or 4 hours after the administration of single dose of corticosteroids. Fever remains in normal limits till the next disease attacks. Oral findings accompanying are typical and pathognomonic. Oft could be complicated by the moniliasis in small children. In general, ophthostomatitis resolves together with fever. Herpetic gingival could be considered, and other bacterial and viral ophthostomatitis should be considered in differential diagnosis. As you see, our patients with PFAPA syndrome in oral findings, ophthostomatitis is most prominent clinical findings, and all patients' family fulfill the Excel sheet. Fever. Painful and bilateral cervical lymphadenopathy is seen during the attacks. Generally, lymphadenopathy appears submandibular extended during the cervical region bilaterally. Except for cervical region, lymphadenopathy is not expected other parts of the body. Our colleagues in our Cerrahpaşa Pediatric Rheumatology departments, hyper-IgD syndrome should be considered differential diagnosis of lymphadenopathy of PFAPA syndrome with hyper-IgD syndrome. As you've seen, our patients with cervical lymphadenopathy and ophthostomatitis. And another findings of the PFAPA syndrome, cryptic tonsillitis is one of the most prominent findings. Tonsils are generally hypertrophic. Prominent pharyngitis could be seen. Nasopharyngeal swab culture and fast streptococcal tests are negative. Tonsillitis unresponsive to antibiotics, but prominent responsive to corticosteroids. As you see in our patients with cryptic tonsillitis with the PFAPA syndrome and other patients, we have a great series in the medical literature in the PFAPA syndrome. Our PFAPA syndrome, to share our objective of this study, to share our experience with the clinical manifestation, natural history, and response rates in a large cohort of patients with periodic fever, ophthostomatitis, pharyngitis, and adenitis syndrome. Medical reports of patients 11 years in our department. We have 607 patients with the diagnosis of PFAPA syndrome. Median age at the disease onset 18 months and 36 months respectively. The duration of episodes 3 days, and median interval between episodes was 20 days. In total of the patients who did not undergo tonsillectomy and adenoidectomy, episodes ceased during the follow-up. Another patients of family history of tonsillectomy and in our patients was 30% of our patients. The most common clinical findings: fever, pharyngitis, ophthostomatitis, cervical lymphadenopathy in our patients. Steroids, most important drugs are on the attacks. Constant treatment was effective in our patients in the 64%. Tonsillectomy was effective of 95% of the patients. As you've seen, our patient series, another PFAPA series in our country, and steroids are responsive all the patients, and the diagnosis of these patients very important problem in clinical practice. A long time before the long time onset of before the age and Marshall criteria and newly proposed criteria for the PFAPA syndrome. Our department investigated of this criteria efficacy of the diagnostic process to evaluate performance of the recently proposed PFAPA criteria in regions endemic for familial Mediterranean fever, as you see in our study groups. And conclusion, recently proposed criteria of the newly PFAPA criteria have high sensitivity but low specificity in region endemic for FMF, like Turkey and other Middle East country. Recently proposed PFAPA criteria have satisfactory sensitivity. Specificity is under expectation with a need for specific criteria. There is a need for prospective study with a higher number of patients. Another study, the role of familial Mediterranean fever gene variants in patients with PFAPA syndrome. We have 167 patients diagnosed according to Printo PFAPA criteria. The aim of the study was to evaluate the frequency of MIF-gen mutation among PFAPA patients and to explore its effects on clinical presentation. As you see in our patients and MEF gene results, about the 40% of patients had no mutation. Another most common mutation in our PFAPA syndrome patients. And our patients, PFAPA syndrome, with the PFAPA syndrome patients with exon 10 mutation, comparing in those non-exon 10 mutation and those without any mutation on the MEF gene, duration of attacks were shorter and age at disease onset was higher than. Most important question this time, is there a modifying effect of MIF gene mutation on phenotype of patients was carrier on mutation? There was no difference response to colchicine treatment between those with and without MIF gene mutation. Printo PFAPA criteria has a better ability to make a differential diagnosis of FMF and PFAPA. This is the first study evaluating the response to PFAPA patients using the colchicine treatment. The presence of MIF mutation increased the response to colchicine. As you know, in the results, we can using the colchicine with the diagnosis of PFAPA patients with positive MIF gene mutation. In our another study, PFAPA syndrome, similar to NLRP3 CAPS patient, we examined the frequency of NLRP3 variants and compare serum NLRP3 levels in patients with PFAPA syndrome. 71 patients diagnosed with PFAPA syndrome, 71 healthy controls, our patients. As you see in our study results, no significant difference was found in the frequency of NLRP3 variants and NLRP3 levels. Main problem in PFAPA syndrome treatment, disease attacks have no response to antibiotics and antipyretics. Studies evaluating the effects of cimetidine and colchicine failed to prove their efficacy. Only treatment agents is corticosteroids. On the attacks, we can use corticosteroid dosage 1 or 2 mg/kg per day. Main treatment objectivity. Our main another study, PFAPA syndrome in our country, very big problem with the endemic familial Mediterranean fever. As you see in our study published in Journal of Pediatrics in 6 years ago, we conclude that MIF gene mutation difference to PFAPA syndrome patients main problem in our country. Our another study big problem is gray zone in the spectrum of autoinflammatory disease, familial Mediterranean fever and PFAPA syndrome. Another problem, another big problem, as you see in our study groups, we have a lot of patients, 131 patients diagnosed with PFAPA syndrome and FMF, 50 patients colchicine unresponsive, another patients colchicine responsive groups. But main difference in these patients, MIF gene mutation, especially positive exon 10 mutation, very important on the clinical findings, our groups. Another groups difference as a result of this type of exon 10 mutation, M694V mutation, colchicine responsive. Another colchicine unresponsive group, after stomatitis, tonsillopharyngitis, PFAPA, positive family history. What is treatment? Another treatment. Tonsillar adenoidectomy represents the only permanent treatment solution. Most of the patients shows good response to tonsillectomy with resolution of symptoms, cessation of the attacks, disease attacks. Previous studies reported the efficacy of more than 90%. As you see in the right side of the slides, our patients after the operation, our patients' tonsils and adenoid tissue. As you see in our previously results, steroids effective on the attacks, colchicine similar to so-so effective is disease duration. Another very important type of the tonsillectomy. We are studied efficacy of long-term efficacy tonsillectomy, adenoid tonsillectomy in patients, our PFAPA syndrome cohorts with our ENT specialist. We aim to evaluate the efficacy and safety of tonsillectomy and adenoidectomy in our patients. We have a long time in our medical school, in our otorhinolaryngology department, 281 patients were reached. As you see in our patients, with also familial fever, 15 patients, and complete remission was achieved in 83% of our patients after tonsillectomy. Only 3 patients have persistent symptoms. In the PFAPA and FMF group, complete remission after the tonsillectomy. Another, there was no statistically significant relationship between response to tonsillectomy, age at operation, and age at attacks free time. As results of this study, tonsillectomy is highly effective in patients with PFAPA syndrome. The relatively low rate of response to tonsillectomy in the PFAPA and FMF groups indicates that patients should be carefully evaluated in terms of FMF and other autoinflammatory disease that may be a combining before making a surgical decision. In a review, our groups, as a main clue for the diagnosis and FMF, upper the cervical region clinical findings compatible with PFAPA syndrome. Lower the clinical findings at the cervical region with the compatible with this part. As you see in our study results and main clue proposal. And we investigated independent risk factor for resolution PFAPA syndrome within 4 years after the disease onset. As you see in our study population, as you see in our study groups characteristics, as you see in conclusion, late disease onset, family history of PFAPA syndrome, lack of headache are associated with the cessation of the attacks in the 4 years in the disease onset. As a conclusion, late disease onset, family history, lack of headache are associated with the cessation in the 4 years after the disease onset. Therefore, patients before mentioned characteristics should be with symptomatic treatments, while those without such feature considered for the early tonsillectomy. Another problem, what is long-term of PFAPA syndrome? We don't know. But last year published a manuscript from the NIH, from the United States, common genetic susceptibility, local link, PFAPA syndrome, Behçet disease, and recurrent after stomatitis. Family history, as you've seen, inflammation-related genes may be influencing the phenotype, and frequency of MIF gene mutation associated with milder clinical disease. And NLRP3 variant frequency is the same as healthy population. This is main problem. Our study group studied on the long term of PFAPA syndrome children. As a conclusion, PFAPA syndrome should be considered in all children younger than 6 age with history of recurrent fever. For the certain diagnosis, cryptic tonsillitis should be noted and the infection should be excluded. In region with high frequency of MEF carriers, the phenotype could be more severe. Treatment options are controversial. Main clues for the diagnosis of PFAPA syndrome: make sure there are at least 3 episodes and all components together for diagnosis. Especially most important point is the diagnosis of PFAPA syndrome, all the clinical findings, and similar 3 attacks. After the proving that cryptic tonsillitis is not caused by infection in the diagnosis, administer steroids and see that the crypts on the tonsil disappear the next day. If the patient has FMF in the family or the patient's MIF gen positivity, evaluated the Conferencein response. Thank you very much for your attention. Thank you very much for your kind invitation. As a big thanks to my colleagues in our department, in our friends. Thank you very much. My best regards to St. Petersburg colleagues. Thank you so much.
Good morning to everyone. First of all, I would like to thank Professor Kostik and all the organizing committee for this kind of invitation to participate in this event. As you can read from the title, I was asked to deliver my presentation on Behçet disease in children. In this presentation, I will provide a general overview on the clinical and diagnostic aspects, but I will also try to focus on the main points of the therapeutic management of pediatric patients affected with Behçet disease. Let's start to try to define Behçet disease. From the pathological point of view, Behçet disease is defined as a systemic inflammatory vasculitis that can affect both small and large vessels, with a major involvement of veins compared to arteries. For this reason, someone referred to Behçet disease as a variable vessel vasculitis. This vasculitis can lead to occlusive phenomena, especially at the level of veins and arterioles, which is characterized by a dominant neutrophil infiltration, even if the inflammatory pattern may vary according to the different organs. The potential involvement of any organ in this pathological process of Behçet disease results in a very variable clinical presentation, since any organ could be injured, even though some are more frequently affected, such as the skin, oral genital mucosa, eye, central nervous system, and joints. Such great clinical variability, along with the fact that, especially at the onset, these manifestations are typical but not absolutely specific to Behçet disease and can be also isolated, even for a long time, not infrequently make the suspicion of Behçet disease and then its diagnosis quite challenging. For instance, as you can see from this slide, and you certainly know, oral ulcers are a frequent manifestation in Behçet patients, but these are also and probably more often associated with more benign diseases, such as the recurrent aphthous stomatitis. However, much more suspicious is the situation when genital ulcers are present, especially in children, or when other more serious manifestations occur alone or in combination, such as uveitis and thromboembolic events, which could also involve the splanchnic vessels or the central nervous systems, in this case especially at the level of cerebral sinuses, but also the parenchymal level, as summarized in the table shown in the following slide. As just mentioned, here you can see the possible neurological, abdominal, and thoracic manifestations and complications that can be observed in Behçet disease patients, along with the main differential diagnosis. As explained, the cutaneous and mucosal manifestations are relatively frequent in Behçet disease and should be carefully considered, especially in children, as an early sign of Behçet, before more serious manifestation and or systemic complications may occur. In Behçet disease, oral aphtha are often multiple and more painful than the common ones associated with the simple stomatitis, even if they are not necessarily larger or of major type. As said, much more unusual are such ulcerations on the scrotum or genital areas in general. Sometimes Behçet disease may also manifest with pustular lesions. A bilateral uveitis, especially if recurrent, should be also very suspicious, and it can involve both anterior and posterior segments. Pediatric patients represent a minor fraction of Behçet disease population. Indeed, pediatric patients represent a percentage between 5 and 15% of all diagnoses of Behçet disease. Juvenile or pediatric Behçet disease is considered when the onset of symptoms occur within 16 years of age. However, we should say that some patients may not be timely recognized, and then some can be diagnosed only in the adulthood, even if their symptoms actually have started in the pediatric age. In the table below, you can see the criteria of the consensus classification for pediatric Behçet disease, which includes oral aphtha, recurring at least 3 times per year, genital ulcerations, which are usually associated with healing scars, other less typical and less specific skin manifestations, which also include erythema nodosum, uveitis, as mentioned before, neurological signs not otherwise explained and not limited to isolated headaches, and any signs of thromboembolism in general. At least 3 criteria are usually required to make a diagnosis of Behçet disease. In this slide, I wanted to show you this recent consensus paper highlighting the limitations of the clinical criteria for pediatric Behçet disease, as previously mentioned, especially in the landscape of monogenic and polygenic autoinflammatory diseases, which may mimic Behçet disease. In detail, the pediatric criteria showed a high specificity but not such a very good sensitivity. Therefore, it is perhaps important to consider ethnical and geographical aspects and also include genetic analysis to improve the accuracy of Behçet disease diagnosis. For instance, this figure shows how geographical and then ethnical factors may affect not only the prevalence of Behçet disease in a specific population, which, as you may know, is especially high in countries located on the so-called Silk Road, going from the Mediterranean Sea until Eastern Asia, but may also affect the type or the relative frequency of the clinical manifestation of pediatric Behçet disease patients. As highlighted in this slide, the phenotypic differences between Behçet disease patients in different populations are also due to genetic factors, and among them we should include the HLA loci and above all the HLA B51 allelic variant. This HLA B51 allele is not diagnostic of Behçet disease, of course, but is strongly associated to this disease, and in some cases its presence can further support the diagnosis of Behçet. Moreover, in addition to be one of the factors of the genetic predisposition to develop Behçet disease, it can also affect its phenotype. Another interesting observation that can be made from this table is that countries with higher prevalence of Behçet disease also seem to have higher percentages of HLA B51 carriers in the general population or controls. Here I have not highlighted the line related to Italy on purpose, since this prevalence information can be misleading, because the prevalence of Behçet disease is quite different between South and North Italy, as described in the text below the table. This figure points out the fact that Behçet disease can be not so infrequent even in areas that are not on the Silk Road. For instance, in Germany, the overall prevalence is not low, which is explained by the immigration patterns and then by the presence of people coming from countries located on the Silk Road. This is an important point, since we should carefully consider the ethnical origins of patients, even if we are working in a low prevalence country for Behçet disease. Unfortunately, many countries included in the previous map may not have epidemiological studies regarding Behçet disease, but they may have anyway a relatively high prevalence of Behçet disease, which is not recorded due to several barriers impairing the diagnosis and or simply because of the lack of epidemiological studies, as just explained. For instance, in Kazakhstan, although it is near the Silk Road, the prevalence of Behçet disease has not been systematically investigated so far. However, our group recently assessed the allelic and carrier frequencies of HLA-B51 in Kazakhstan and in detail in the people included in the National Bone Marrow Donors Registry. Then we retrieved the analysis of the HLA-B51 allelic and carrier frequencies in different countries where actually the Behçet disease prevalence is well known. We noticed some correlation between the genetic aspect and the disease prevalence. If we consider this relationship based on the actual HLA-B51 frequency in Kazakhstani donors, the Behçet disease prevalence could not be so low and might be comparable to that observed in some Middle East countries. Now let's start talking about the therapy. Of course, the drugs used to treat Behçet disease patients are overall the same used in other rheumatic disorders and include steroids, topical and systemic, non-steroidal anti-inflammatory drugs, topical and systemic, conventional disease-modifying anti-rheumatic drugs such as azathioprine, colchicine, and several others, and finally biologics, which have also changed the treatment and outcome of Behçet patients in a significant way, as they did in most rheumatic diseases and not only. As discussed, the clinical manifestation of Behçet disease vary according to the individual patients, in terms of both severity and involvement of specific organs and systems. Therefore, the types of pharmacological approach and the intensity of the treatment is driven by these aspects. Basically, different drugs and dosage can be used in different patients based on their specific clinical pictures, complication, severity, and in general disease activity. Similar considerations can be applied to the pediatric patients affected with Behçet disease. In general, acute and severe active diseases, especially if vital organs are involved or there is the risk of permanent lesions, the initial approach is based on systemic steroids, which are usually associated to other conventional immunosuppressors or biologics according to the individual cases. Mucocutaneous lesions, especially if isolated, are usually treated with local therapies, including topical steroids, but colchicine can find space as a systemic treatment in this pathological setting. It will be too time-consuming to address all the specific treatments for each specific typology of Behçet disease. Therefore, I decided to focus on the treatment of mucocutaneous manifestations, which are the most common problem that any pediatrician managing Behçet disease children may encounter. And after that, I will also focus on the role of biological drugs in Behçet disease. As regards the mucocutaneous manifestations, topical antiseptics like chlorhexidine oral rinses or gels, topical non-steroidal anti-inflammatory mouthwashes, topical anesthetics like 2% lidocaine spray or gels, and topical steroid gels or spray are available to treat oral and genital ulcers. Antibiotics can be considered only when an infectious agent is suspected to play a role as a trigger factor of the disease flare. Someone also used sucralfate in patients with oral ulcers, but there is a conflicting evidence on its efficacy. In absence of other organs involvement requiring specific treatment, a systemic therapy in patients with mainly mucocutaneous manifestation is established when oral lesions are severe and or there are genital ulcers and or these lesions are responsive to the topical treatment or are recurrent. As mentioned, the colchicine has been widely used as systemic treatment of this patient, at least as a first line. As a posology regimen, we could refer to the EULA recommendation for colchicine in patients affected with familial Mediterranean fever, which recommend different doses according to the age of the pediatric patient. Then less than 0 or no more than 0.5 milligrams day in children younger than 5 years old, 0.51 milligram per day in those between 5 and 10 years of age, and 1.5 milligram per day in patients older than 10 years of age. Of course, if there are very severe patients, usually with extra mucocutaneous manifestations, biologics should be timely considered. Anti-TNF are the main biologics used in this pathological setting, but others have been described, including anti-interleukin-1, secukinumab, ustekinumab, and also interferons. However, the experience with biologics in pediatric Behçet disease is still relatively limited, especially compared to the adult counterpart. For instance, this is one example from our experience in Astana with Dr. Maikesha Silbekova and Dr. Zaurieh Mukusheva. This patient had recurrent and severe mucocutaneous manifestations without any relevant neurological or thromboembolic or specific gastrointestinal involvement. However, his general conditions were deteriorating with significant impairment of the nutritional status. Despite an initial treatment with systemic steroids and the use of colchicine, the specific and general clinical response was definitely unsatisfactory, and adalimumab was added to colchicine at the dose of 20 milligrams every other week, which allowed the patient to achieve a complete and stable resolution of the mucocutaneous manifestations, in addition to a catch-up of his general condition, growth parameters, and nutritional status. As you can see here from our case-based review, at that time in 2019, there were very few experiences with adalimumab in pediatric patients affected with Behçet disease. However, our case, the few previous articles, and I can say those reports which came later in the following years, supported the good efficacy and safety of adalimumab in children with Behçet disease. More recently, this systematic review was published about the use of biological drugs in children with Behçet disease. It is clear that biologics are mainly used when there is ocular involvement or other specific non-mucocutaneous organ lesions or when multiple systems are affected. Anti-TNF agents have been the most used biologics in these children. Among this category, infliximab and adalimumab were the most prescribed. Much less used were other biologics, including anti-IL-1, anti-IL-6, and others. However, a specific mention should be done for interferons, especially alpha, which were used in around 10% of pediatric patients. This figure from the same article graphically summarizes the use of different biologics according to the specific organ involvement in Behçet disease children. Uveitis and ocular involvement in general seem to be one of the main indications for the biological treatment in pediatric Behçet disease, and is mainly treated with anti-TNF drugs, both infliximab and adalimumab. However, also interferons have been used for this complication. Etanercept, another anti-TNF drug, was mainly used for those patients with arthritis as a main clinical complication. Much more heterogeneous in terms of type of used biologic is the scenario in other pathological Behçet disease-related contexts, such as gastrointestinal and neurological diseases. As said, a specific mention should be given to interferons. Actually, the use of interferon alpha in Behçet disease adult patient is not a recent finding. However, again, the experience in children is much more limited. In children with Behçet disease, interferon alpha has been used mainly in patients with central nervous system disease, refractory uveitis, or in general unresponsive disease, or unusual and severe manifestations where previous lines of treatment were not working properly. Most of these reports suggested the dose between 1.5-3 million units initially for 3 times a week and administered subcutaneously. Anyway, if you want to check the details, you can refer to the articles that I included in this slide. To conclude, the diagnostic suspicion and then the final diagnosis of Behçet disease in children can be very challenging. The identification of the HLA-B51 in one patient can be a supportive finding, but is not diagnostic itself for Behçet disease. Specific diagnostic criteria for children are available, but they still need further improvement. Anyway, a prompt diagnosis of Behçet disease in children is very important in order to prevent them from further complications and negative impact on their development during the growth and the maturation processes, especially now that several drugs, including biologics, can be effectively used to control the disease. Thank you very much for your attention and again for the opportunity to be part of this nice event. Thank you again.
Good morning. First of all, I would like to thank Prof. Mikhail Kostik for the kind invitation to participate in this valuable scientific meeting. I hope my talk will meet your expectation. As you can see, my talk entitled monogenic lupus and autoinflammatory disorder, finishing frontiers. So in the coming 25 minutes, I will outline the following: the relationship between systemic autoinflammatory disorders and monogenic lupus, and I will use 2 cases encountered in my practice to highlight this issue. I have nothing to disclose relevant to this presentation. I think it's valid to ask a question: what is the link between systemic autoinflammatory disease and monogenic lupus? As we know, autoimmune diseases and autoinflammatory disorders are the major component of inflammatory conditions. Now, what is the relationship between autoimmunity and autoinflammation? Clearly, there is some similarity and differences between the 2 conditions. The similarity in form of both conditions do have immune system malfunction and directed against self. This is the reason we call it auto, and both share same symptoms, mainly involving skin and musculoskeletal system. Also, they include monogenic and polygenic condition. Now, the differences mainly in the etiopathogenesis, the autoimmune diseases characterized by high titers of autoantibodies and associated with autoreactive antigen specific T lymphocyte, and mainly the defects in the pathways of adaptive immune system, while the autoinflammatory disorder are characterized by lack of autoantibodies, and the main effect involved inflammatory cells in form of monocytes, neutrophil, but not lymphocyte. And they characterized by unprovoked attacks of fever, and the main defects in the pathways of innate immune system. Now, this cartoon just to show you the distribution of most of the autoinflammatory diseases and autoimmune diseases, and you can see the relationship between the autoinflammation in relation to the axis of innate immunity and the autoimmunity in almost in line with the adaptive immunity defects. And you can see the sporadic lupus almost halfway between the autoimmunity and autoinflammatory disorders. Now, saying that the innate and adaptive immune mechanism work closely together, and we have to remember that autoimmune and autoinflammatory disorder overlap and are frequent features of inborn immunity. We know that there are evolution in the concept of systemic autoinflammatory disease. The classic autoinflammatory disease in form of familial Mediterranean fever, but now we have more and expansion, and the concept has extended beyond the classic systemic autoinflammatory disease. If we just remind ourselves about the classic autoinflammatory disease, and I will use the Byron-related autoinflammatory disease as an example, and FMF is the best example. These disorders are characterized by marked association with interleukin-1 beta, and we know that this cytokine play a role in the pathogenesis of many inflammasome-related diseases, and many experts thought they may call it interleukin-1 mediated diseases. However, there are with the advanced in molecular genetics and immunological testing, there are many or additional innate immune pathways impacting pro-inflammatory cytokines, and diverse innate immune pathways of interferon type 1 play a central role in pathogenesis of several new or rare systemic autoinflammatory disease. Currently, autoinflammatory disease properly classified under these categories: inflammosomopathy, actinopathies, NF-kappa mediated disorder, and interferonopathies. Now, these rare diseases are not following the same pathway of the classic autoinflammatory disease, and the most important for the clinician, the phenotypic features deviated from the typical characteristic of classic systemic autoinflammatory disease, with many exceptions. This table just to show you how expanded the autoinflammatory disease, and you can see interleukin-1 mediated diseases, or we call it inflammosomopathy, and type 1 interferonopathies, and NF-kappa mediated diseases. And you can see here under interferonopathies, monogenic lupus, considered one of the autoinflammatory disease. Now, systemic or lupus is an umbrella for different types of lupus, and we are familiar with systemic lupus erythematosus, which is the most common type, but we are seeing also cutaneous lupus. We have also neonatal lupus and also drug-induced lupus. And I would suggest to add monogenic lupus in the layout of lupus because it has some peculiar clinical and clinical manifestations, and probably they have different etiopathogenesis, as we can see in the coming slide. Now, I prefer to define monogenic lupus as a complex construct marked by a spectrum of phenotypes characterized by paradoxical combination of autoimmune and immune dysregulation. And I'm saying immune dysregulation because the interferonopathy defect has significant role in the pathogenesis of monogenic lupus. And all this happened due to various pathogenic mechanisms linked to a single gene variant. So far, there are more than 35 genes predisposing to monogenic lupus, and you can see in this table the complement C1q, C2, C4, and also DNase 1, DNase 1L3, and others are responsible or responsive to some of the clinical manifestation of monogenic lupus. The important point here, most of these genes or the monogenic lupus associated with genetic genes characterized by predominant hyperactivation of interferonopathy or interferon type 1. There are many reports and cohorts have been reported showing monogenic lupus due to different gene type, and we have the privilege to publish some of these cases. And for instance, DNase 1L3, we are the one who reported for the first time, and we have also other gene like SIG15 and rare entities also due to rare gene mutation. Now, I think we have clear association idea about the interferon type 1 role in the pathogenesis of lupus in general and monogenic lupus as well. We know that the second leading cause of monogenic lupus is a mutation in gene related to interferon regulation. And this is the reason we call it interferon dysregulation. In this cartoon, you can see the interferonopathy, most of the genes here can cause monogenic lupus manifestation. Now, this cartoon, just to summarize what happened in case of lupus, as we know, there will be a defect in clearance of apoptotic and necrotic cells, which lead to self DNA, double-strand DNA availability, which is the major source of self DNA's double-strand DNA. As this gene or protein exposed to autoreactive B cell with help of autoreactive T cells, anti-double-strand DNA will produce, and the immune complex formation led to activation of phagocytes and dendritic cells. All these will lead to interferon type 1 production, and we know that interferon type 1 is the driving force for lupus pathogenesis by precipitating in inflammatory reaction and dendritic maturation and activation of autoreactive T and B cells. You can see this spectrum between the auto-inflammatory and autoimmune, the role of type 1 interferon probably in the halfway between the autoimmune and auto-inflammatory disorders. And we know that monogenic lupus patients have high levels of interferon type 1 and correlate with high ANA and also disease activity. Furthermore, the interferon type 1 overproduction as a stimulator or a sting deficient patient can lead to severe lupus and vasculopathy, as you can see in this cartoon. We have also a good cohort of patients due to manifested with the inborn error of immunity, and they presented with the lupus manifestation, and most of these cases have genetic defect, pathogenic genetic mutations known to cause lupus manifestation. Here I will just share with you two cases to elaborate the relationship between the auto-inflammatory disease and monogenic lupus. The first case is a 12-year-old boy presented to the local hospital at the age of 3 years. He had a history of intermittent fever with polyarthritis, mainly affecting ankles, knees, and small joint. He ended with contractures of the fingers, but there was no skin rash or lymphadenopathy or organomegaly. He has two cousins from paternal side known to have lupus. During follow-up in the local hospital, he showed poor appetite with significant weight loss, and he had headache associated with bilateral bibble edema requiring Diamox treatment. This photo just to show you the contractures of his finger bilaterally, and he had active synovitis. During follow-up, he showed he was complaining of low back pain and talgic gait, and we found he has hepatosplenomegaly but no lymphadenopathy, and he had also bilateral bibble edema as confirmed by ophthalmologist assessment. This slide just to show his lab, and you can see he has positive Combs test with leukopenia and low albumin with high inflammatory markers. Urine analysis was normal, and he had high ANA double-strand DNA with low complement, low C1q, and also he has positive rheumatoid factor, which is not unusual in lupus patient, as we know. And he had negative neuromyelitis optica antibodies. We asked for that because he had bibble edema. The serum immunoglobulin were normal. However, he had lymphocyte marker depressed with intact blastogenesis. And this X-ray showed bilateral hand X-ray with osteopenia, no erosive changes, but you can see the deformities affecting mainly the fifth fingers, and this is non-erosive and no lytic lesion as well. Because of the headache and bibble edema, we asked for MRI, which showed white matter changes, as you can see. And as per neuroradiologist, this may be consistent with vasculopathy rather than real white matter change. With that, we proceed for genetic testing, and interestingly, it showed homozygous mutation in DNase 2 gene, which is known to cause high interferon levels and known to be one of the type 1 interferonopathies, and this may explain his lupus manifestation. With that, we ended with the diagnosis of monogenic lupus. And interestingly, there is a report showing similar case to our patient with DNase deficiency, and they conclude DNase to plays a central role in the clearance of nucleic acid generated through apoptosis, and this is also associated with chronic activation of type 1 interferon signals, and this is the reason he had ongoing inflammation. What we did for that patient, we treated him as usual with the treatment for lupus with plaquenil, hydroxychloroquine, and he received a course of steroid. Fortunately, we were able to wean it and stop it, and currently he is on Celcept, but was stopped because of the side effect, and he is receiving belimumab on every 6 weeks on weaning schedule, and we are happy with his progress as he showed no more headache, papilledema resolved, and no more arthritis, and his lab result normalized. The second case is a 17-year-old girl, was well till age of 7 years of her age. She developed gastroenteritis-like manifestation complicated by seizures and consciousness impairment. She showed thrombocytopenia and was managed as infectious meningoencephalitis in the local hospital. Interestingly, she had normal low C3 and with ANA positivity. She received IVIG in the local hospital and referred to us. And you can see here, this is what happened at age of 11 years. She developed fever and oral ulcers, and she developed lesions around her eye with ulcerated lesions, even around the eye and the mandible. So we thought this is maybe something related to her drug, and we did workup to rule out drug-induced lupus, came negative. However, we thought about lupus, and we treated her accordingly, but unfortunately she lost for her follow-up. At age of 14, she presented again, however, this time with fever, with weight loss, fatigability, oral ulcers, arthritis, and proximal muscle weakness. And this is her lab showed borderline white cell count, high inflammatory markers, high muscle enzyme, and high liver enzyme as well. And she had low complement, high ANA, and double-strand DNA. Interestingly, we did MRI. It showed significant, massive myositis affecting her proximal muscle, hip girdle muscles. So the genetic testing confirmed homozygous mutation in ISG15, and this is known to cause her symptoms in form of inflammatory manifestation, and namely with the lupus-like manifestation. And it's known that ISG15 expression is relatively high in lupus patients in general, and it's correlated with disease activity, as you can see in this slide. We treated this patient with hydroxychloroquine with MMF and belimumab. She received 11 doses. She's off steroid, and she's currently doing fairly well with normal inflammatory markers, and the double-strand DNA almost negative with normalized C3, C4. So I have to say the available drugs used in monogenic lupus are not evidence-based. We are using the same cocktail for lupus patient treatment in form of corticosteroid, conventional DMRs, and of course hydroxychloroquine, and the biologic agent in form of belimumab and rituximab. And recently we can consider JAK inhibitor as well, and infrolumab as one of the options, but not used or tested in pediatric age group. So what did we learn from these cases? I think this is important to remember the early onset manifestation of lupus in children should raise the possibility of monogenic lupus, and there are a good percentage of monogenic lupus patients have genetic defects, and these genetic defects associated with the chronic activation of interferon signals. And as per the new classification of autoinflammatory disease, monogenic lupus can be considered as one of the autoinflammatory disease, providing that the pathway or involved pathway related to the interferon pathway. So the take-home message from this presentation, the concept of monogenic autoimmune autoinflammatory disorder has evolved to include the new rare diseases and syndromes. Monogenic lupus is a distinctive entity and may differ from sporadic childhood lupus. It is highly complex disease with marked heterogeneity between patients due to different etiopathogenesis, causing anything from mild to life-threatening diseases. It may overlap with other monogenic interferonopathies, namely systemic autoinflammatory diseases, and a consensus is needed to formulate clinical and therapeutic approach for monogenic lupus. With that, I will stop, and I wish to be in presence with you to discuss and to hear your comment and received your question. Thank you very much.